And lastly, Courtney and I are always available offline to talk one-on-one about aspects of your application. So please don't hesitate to drop us an email. Okay, next slide, Courtney. Okay, during today's webinar, I'm going to start us off by providing a brief overview of the ACO certification program and a refresher on some key concepts in ACO certification. Then I'll turn it over to Courtney, who will spend some time reviewing the application criteria for certification. This includes the prerequisites to apply, the application assessment criteria, and this year's supplemental information questions. Courtney will also walk us through the updated health equity requirement, as well as provide an overview of this year's application process and timeline. And as I mentioned, we'll leave plenty of time to answer any questions you might have, so please drop them in the chat as they occur to you. Next slide, please. Before we dive into our main topic today, we did want to take a few moments to refresh folks on the basics of the HPC's ACO certification program. ACO certification is written into the landmark 2012 state cost containment law that created the Health Policy Commission. Given the proliferation of risk contracts and ACO programs over the past 15 years, the certification program exists to create a set of multi-payer standards as a means of facilitating care delivery transformation. To that end, we strive to make sure our standards align with and complement other requirements that exist in the market as much as possible. Another important goal of the program is to advance knowledge and transparency about ACOs in the Commonwealth. To that end, we have produced materials like short profiles of each ACO and high-level summaries of ACO strategies to transform care delivery. We're also interested in exploring ways to facilitate learning across the healthcare delivery system, and will continue to look for opportunities to do so. As a historical note, the ACO certification program launched in 2017, and we're now kicking off our 5th certification cycle. Since 2021, the certification standards have focused on ensuring ACOs are positioned to learn from and iterate on their activities over time. Under what we call the Learning, Equity, and Patient-Centeredness or LEAP standards, we built on our tradition of recognizing core competencies of ACOs to embrace the ACO model as a catalyst for learning and improvement among healthcare organizations. Finally, in the insert here, you can see a few key program stats. As of this year, there are 17 certified ACOs in the Commonwealth, representing nearly 100 risk contracts and more than 3 million covered lives across commercial, Medicaid, and Medicare lines of business. Next slide, please. Okay, a quick note about definitions. The way we define applicants for ACO certification is going to remain the same this year as it has since the launch of the program. All entities within your organization that hold and manage commercial, Medicare, and/or Medicaid risk contracts in Massachusetts. These are the entities that we refer to as component ACOs. These must all be included in your application. For purposes of certification, the applicant is the entity within your health system or provider organization that has component ACOs. Sometimes the applicant entity holds risk contracts, sometimes it does not. Each component ACO and the applicant itself, if the applicant holds any risk certification requirements. If some or all of the component ACOs in an application are meeting their requirements in unique ways, then the documentation included in the application will need to show how each component ACO is meeting each requirement individually. Next slide, please. Here you can see a snapshot of the ACO certification requirements. Courtney will walk through each of these in more detail in a few minutes. Those of you who have been involved in certification in the past will be familiar with the structure of the application. We have a handful of prerequisite requirements that ensure basic legal and definitional requirements for ACOs are satisfied. We have 5 assessment criteria and a health equity requirement that form the core of our programmatic requirements. We evaluate applications based on these criteria. And then finally, we have a small number of supplemental information questions. Responses to the supplemental information questions are required, but we do not evaluate applicants based on those responses. We use the supplemental information questions for various purposes, including information gathering to inform potential updates to the standards, as well as to support our goal of advancing knowledge and transparency around ACOs in the Commonwealth. Overall, these requirements have largely remained the same since 2021, apart from the health equity requirement and the supplemental information questions, which we do update every cycle. Next slide, please. So that said, there are some minor updates to the assessment criteria this year. We've changed the order of the criteria to proceed from high-level organizational and cultural activities to care delivery supports down to the individual patient experience. We've simplified the response options under the culture of performance improvement criterion, emphasizing leadership tools and incentives. We've reframed 2 criteria. Patient-centered care is now improving the patient experience, and data-driven decision-making is now high-value care. And we are continuing to advance the program's health equity requirement. Next slide, please. One final note here on confidentiality before I hand things over to Courtney to walk through the requirements. Since the inception of the certification program, we have had in place a confidentiality policy that seeks to balance the value to the market of having some transparency with real business confidentiality interests. We certainly recognize that materials submitted in the application often contain sensitive financial, strategic, or operational information. To that end, there's only a small set of data that we plan to publicly report on in an identifiable way, and that's listed in the blue box here. You can find those basic pieces of information about ACOs in the ACO profiles that the HPC periodically releases. All other information submitted for certification will be kept confidential by the HPC unless the ACO specifically consents to release of information. And there will be an opportunity on the application to offer that consent for responses to various questions. I do want to emphasize, though, that the HPC does have the authority to publicly report information at an aggregate de-identified level. With that, Courtney is now going to talk us through the application.
Thanks, Mike, and hi, everyone. As Mike mentioned, I'm going to go through the criteria for certification, including prereqs, assessment criteria, and our supplemental information questions. I'll also review some of our changes to the health equity requirement, and then we'll very briefly go over process and timeline, and then save some time for Q&A. So Mike's going to be manning the chat. We'll pause if anyone has some questions throughout, but we'll try and save them for the most part towards the end. So beginning with the first section of the application, there are several prerequisites that the applicant needs to meet by providing information on ACO governance, risk contracts, structure, and quality performance, as well as attesting to a series of legal and regulatory expectations for organizations applying for certification. So these legal and regulatory attestations include attesting that the applicant, inclusive of any component ACOs, has complied excuse me, with each of the statements listed here in orange on the right-hand side of the slide. Applicants will need to provide information on their governance structures, including an organizational chart. And if your organization has any component ACOs, you will need to provide separate org charts for each ACO governing body. You'll also need to upload a risk contracts template that we provide. This template includes details on the payer, number of covered lives, financial terms, description of quality incentives, and a description of health equity incentives included in the risk contracts. Lastly, applicants are asked to upload final ACO level quality performance on all measures included in risk contracts for the most recent performance year. Before we dive into the assessment criteria, let's just review some of the documents ACOs can provide to adhere to our standards. In each section of the application, we specify our expectations for meeting the standard, and we'll ask for a primary source document or original narrative, or we will provide a template to complete and upload to the application portal. Primary source documents are materials created within your organization from the past 2 years. This could be an internal memo, a summary report, a presentation, or a de-identified screenshot of a tool being used by teams, among other materials. There will also be a text box for you to describe the primary source document and explain how it aligns with the standards set in the assessment criteria. Our hope with the primary source documents is that they streamline the application process for ACOs where possible, and where possible, we avoid requiring you to create net new material for the application. So overall, we're approaching the primary source documents as a way to taking an example-based approach with the certification process. We're looking for ACOs to provide specific examples that illustrate the approaches and activities that meet our standards. This allows us to understand how the ACO functions without requiring staff to create new descriptions. Another type of documentation is the original narrative, which is a written documentation of how the ACO meets an assessment criterion. So you'll have the option to upload these in the application as a Word document or PDF in lieu of the primary source documents. And we have more guidelines on what to include in the narrative responses in the PUG. So while we do offer the original narrative as an option for each assessment criteria and supplemental information section, we've found that the primary source document option is preferred by ACOs. We also have a few sections where we ask ACOs to complete and upload an Excel template provided by the HPC, such as the health equity requirement and the risk contract template that we were just discussing. Okay, so as Mike mentioned, we've reorganized the criteria this year to clarify and streamline the application. And we've also reframed some of the individual criterion requirements. So AC1, culture of performance improvement, for this, we're asking you to demonstrate how the ACO fosters a culture of performance improvement, innovation, and learning to improve the patient experience and value of care delivered. So broadly speaking, this criterion is an opportunity for ACOs to demonstrate how they impact and influence providers to be more than a sum of their parts. So for example, how they influence culture change, provide support and guidance to foster improvement across the ACO to meet strategic goals. We've offered 3 ways to demonstrate a culture of performance improvement, which is met by identifying at least 2 of the options that you see on this slide. This is one of the streamlined criterion we were just mentioning, focusing now on 3 ways to demonstrate a culture of performance improvement down from 6 in our former standards. We did this partly because the original question was very broad and many of the selection options went unused by respondents. The essence of this question really is to understand what structures are established by the ACO to track performance and how the ACO encourages providers to modify processes to improve performance, and then also to discover what other supports or systems are in place to facilitate success. Some examples of primary source documents that might meet this standard include agendas, minutes, or written summaries of internal meetings or organizational management activities aimed at identifying opportunities for improvement, dashboards or other tools for tracking quality and financial metrics against goals, memos, presentations, or summaries demonstrating implementation of systems or learning or process improvement approaches like Lean. So there are a lot of options for the kinds of materials that could be submitted to meet our certification standards. AC2 is now population health management programs. We now focus on how ACOs develop, implement, and refine programs and care delivery innovations to improve care coordination, better manage health conditions, and improve the health of its population. So like many of our criterion, it's split into 2 parts. In the first, we're asking ACOs to describe their approach for collecting and using data to stratify its patient population for inclusion in population health management programs. To meet the second portion of the standard, we're asking ACOs to complete a template that we provide to report on the suite of the population health management programs, including the specific interventions, target patient populations, number of patients served, and information on metrics and targets for measuring impact of these programs over time. So for this template, we're asking for the overall suite of PHM programs, but of equal importance are the columns that provide details about each program. So in particular, we're collecting information to understand how the ACO manages these programs, including setting standards and evaluating its success and then iterating to improve the programs. So this is a good example of the learning aspect of our LEAP standards. We want to see how ACOs are using information on performance to improve processes. So AC3 high value care delivery is another criterion we've made some changes to. The overarching goal is that ACOs demonstrate commitment to using the best available evidence and data to support high-value care delivery. It was formerly called data-driven decision-making. The requirements for this criterion are similar, but we've refocused it to demonstrate how data is used to provide evidence and guidance to support ACOs in providing high-value care to patients. So this is demonstrated in two parts. First, documentation should show how ACO adopts processes or tools that make available reliable current clinical knowledge at the point of care to facilitate learning among providers, decrease practice variation, and support provider adherence to evidence-based guidelines. So examples of some documentations that could meet our standards include presentations describing an initiative to reduce low-value care, a strategy document or internal communication encouraging use of a particular decision support tool, or an event agenda for a learning opportunity for providers. For the second section of this criterion, we're asking ACOs to show how actionable data is collected and offered to providers at the individual provider or group level, and how these data are benchmarked to peers or an external standards. So we've changed this question to clarify that overall, we're looking to see what ACOs are sharing with providers to improve performance. So this could be, for example, a template or a de-identified example of a quality performance report. The standard for AC4 whole person care is that the ACO recognizes the importance of non-medical factors to overall health outcomes and cost of care, and seeks to integrate behavioral health and health-related social supports into its care delivery models. So to start, we want to see how the ACO is advancing behavioral health care into primary care settings and how discrete goals are set and measured to support this work. For the behavioral health standard, we didn't set a minimum a threshold or a minimum place for achievement because we understand there's a significant amount of variation among providers' capacity, and there are a lot of challenges beyond the control of the health system, such as workforce deficits. In general, we're looking for advancement of the ACO's approach to BHI rather than absolute achievement. So for this, we'd like to see what's changed in the past 2 years and where the ACO is strategically seeking to go and grow in the coming years. For AC2, we want to see evidence on how the ACO is gathering appropriate data. Gathering appropriate data to understand and address patients' health-related social needs, in particular through screening and referral relationships. Similarly to the BHI section, we're looking to see how ACOs set and measure progress on specific goals to improve the effectiveness of these processes. So we know this is a priority area for the Mass Health ACO program in particular, but we want to see how health-related social needs are being met for the entirety of an ACO's patient population. And finally, so we have AC5, improving the patient experience. This criterion focuses on how the ACO collects and uses information from patients to improve their experience. This is another standard we've made some modifications to. Previously, we called it patient-centered care, and we narrowed the scope to focus specifically on how the ACO seeks to collect data, engage patients, and improve their overall experience of care. So the two sections of this criterion are designed to support and inform each other. For the first section, AC 5.1, ACOs must demonstrate how they regularly monitor and assess aspects of the care experiences of the patients. So examples of primary source documents for the standard could be summaries of patient experience surveys, feedback received during focus groups, or PFAC meeting minutes. AC 5.2 should then demonstrate how the data is used to inform the ACO strategy and organizational level initiatives for improving the patient experience. Mike, before I move on to SI questions, do we have any questions from the folks on the call? Okay, great. All right, so we'll get right into the supplemental information sections. So as a reminder, we don't evaluate responses for the SI section, but the ACOs must provide answers for each of our questions. The SI questions generally have structured response options like checkboxes, but we provide opportunities for the ACOs to extrapolate on their responses through a text box or submitted narrative. So for SI1 this year, we're asking you to identify which areas, if any, the ACO is pursuing strategies to incorporate a health equity lens. Each of the selections align with our assessment criteria, and we're asking for information on how the strategies, we're asking for information on those strategies and if they differ by component ACO. So we're looking to understand how, if at all, ACOs are using a health equity lens in the areas of operations that align with each of our assessment criteria. We do have a health equity response template that I'll go over in a few slides, but that is to understand how the ACO is approaching health equity as a broad system. And we also want to understand how the ACO may be utilizing a health equity lens and its approaches within the context of our criteria. The next two SI questions are previous questions we asked in 2019 with some slight modifications. Our goal is to see what has changed, if anything, in ACO operations and strategies over the years. So for this SI section, high value care, that's what we're focusing on, high value care. In particular, we're looking into how the ACO has developed strategies to reduce instances of low value care and address unnecessary utilization. So for each area selected, we've requested that you submit a brief description of the strategies and approaches taken. Identifying opportunities for reducing low value care has been an interest area for the HPC for many years. We've released a summary of responses from the 2019 applications, and our research and cost trends team has reported on rates of low value care and its impact on the cost of healthcare in the Commonwealth. So this is a good example of how your answers may inform the HPC's future research and policy work. Finally, for the last SI question, we have distribution of shared savings and performance-based compensation. In this section, we're focusing on how ACOs are distributing shared savings and losses, the approach to performance-based compensation models for providers, and what factors are considered in developing performance-based approaches. We're also looking for information on the percentage of total provider compensation that is performance-based. One new question I'll highlight that isn't noted explicitly on this slide is that we're asking about the difference in provider compensation between specialists and primary care providers, if there is. Okay, so next we'll review the details of our updated health equity requirement. This is the third cycle where we've required some form of health equity response. Our goal is to collect information on health equity activities at regular intervals with the expectation that ACOs will demonstrate increasing sophistication and progress in these areas over time. We've worked to align our expectations and our approach with those of other stakeholders in Mass, focusing on promoting health equity, such as Mass Health, private payers like Blue Cross, and others. And improving health equity remains a big priority in the Commonwealth, and we continue to believe that ACOs are an important vehicle for achieving health equity. This year, we've made some changes and raised the bar for health equity, for the health equity requirement. As a brief overview before I dive into the details, I want to remind you all that there are 3 activities that must be described in the template: collection and use of patient socio-demographic data, meaningful engagement with patients, and goals for advancing health equity in strategic plans by changing or adopting new processes. I want to note two new changes to the standards. So we're now expecting ACOs to stratify at least 2 metrics tracked at the ACO level using at least one RELD SOGIS variable. We're also expecting that new organizational policies or operations have been adopted to achieve strategic health equity goals. I'll discuss this more in detail in the coming slides, but I wanted to take note of that here. So each of these activities will need to be answered at the component level, and most of you have received a template from us that is designed for your specific ACO. If you haven't, please reach out to us via email and we'll work with you to get you the document. All right, so we'll dive into the details. For this activity, data-driven interventions, ACOs must describe how they collect data to identify health inequities in their patient population and design programming to address the inequity. So this year, we're looking for ACOs to show that they are incrementally expanding the scope of their data stratification activities as they continue to build up their data collection capabilities and work to integrate equity into quality improvement approaches. We know the progress for advancing health equity isn't linear. but we wanted to see continued focus on addressing identified inequities. So to continue this incremental progress, the standard is now that ACOs are stratifying at least 2 metrics using at least one RELD SOJUS variable. So in the template, you'll see there are drop-down menus for you to select the appropriate status for each component ACO. And there are additional columns where you can provide descriptions to illustrate the progress that has occurred since the last certification, as well as any expected or planned activities for the coming 2 years. The next activity is patient engagement. So ACOs should be meaningfully engaging patients affected by the identified health inequity to incorporate their perspectives into the design and implementation of health equity programs. We're keeping this section as reporting only for now, so you will need to select the appropriate status per component ACO and illustrate the progress in the past 2 years and commitments for the coming 2 years. For this activity, we understand ACOs are at different points at designing and implementing interventions and different points in determining how to effectively engage their patients. So by keeping this as reporting only, we'll be able to understand where progress has occurred while being mindful of the challenges that ACOs are facing. Finally, the ACOs must demonstrate how they have incorporated health equity goals into strategic plans and implemented programming based on these goals. Last cycle, this was a reporting only activity. This year, we are setting the expectation that ACOs have changed or adopted operations to achieve their equity goals. This can be demonstrated in a variety of ways, such as making available dedicated staffing, funding, or technology for these equity efforts. So similar to the other activities, you'll have to select appropriate drop-down status and provide a description on the previous 2 years' progress on these activities and expected activities in the coming 2 years. Okay, so that was a lot. I'm going to spend just a brief minute or two on process and timeline, and then we can get into Q&A. So right now we are in the process of starting the application cycle. We're doing this application requirements overview webinar right now. We're going to launch office hours starting next week, which I'll show you some more details on a subsequent slide. And we're always available to answer any questions you may have as you're working on your application. We'll be opening the application portal no later than early September. We will have a training to go over how to use it, and we'll provide some slides with some how-tos and troubleshooting information. Applicants will complete the applications within the portal itself in the month of September, and then applications are due October 1st. We'll spend the remainder of the calendar year reviewing your submitted applications, returning with any questions that we may have, and determinations for certification will be issued by December 31st of this year. So if you have any questions, you can always contact Mike or myself at hpc-certification@mass.gov. We also have an updated and streamlined website we'd love for you to take a look at. We'll have up-to-date information there, as well as some materials, including the PUG, so you can see the link here. And then finally, we will be starting weekly office hours next week. They'll be on Wednesdays from 11 to 12 p.m. So if you have interest in that, we will be sending out calendar invitations for that. So the office hours are just an opportunity where Mike and I will have a Teams meeting open for an hour. If you have any questions about your application or about the application process, you can pop on and ask us a brief question during that hour. Mike, any last thoughts or comments before we see if there are questions?
No, I don't think so.
Great.
So please feel free to drop any questions in the chat, or I think we're a small enough group. If you want to just unmute, that's fine.
I know you already said it, Courtney, but when are these slides going to be sent out just for us to be able to have on hand?
I can send them out by the end of today.
Okay, great. Thank you.
Well, we can probably wrap, but folks are, as Courtney said, welcome to join us on Wednesdays. Drop in, chat, any questions that come up as you're thinking about your applications, and you can always reach us offline with any questions. I'm always happy to talk through. Thanks for joining us today, everybody.
Thanks, everyone.
Thank you.
Thank you.